Ladies and gentlemen, we now move on to the Professor K. Rajasuriya Memorial Oration. This year, the oration will be delivered by Dr. Asha Wettasinghe, Senior Lecturer in Physiotherapy at the Faculty of Medicine, University of Colombo. The oration is titled A Multi-Domain Fall Risk Model in Diabetes, From Screening to Prevention. May I now invite the audience to kindly rise as the ceremonial procession, led by the orator, Dr. Asha Wettasinghe, enters the hall. Thank you. Please be seated. I now invite the orator, Dr. Asha Wettasinghe, together with Vidya Jyoti, Professor Prasad Kadlanda, President of the Ceylon College of Physicians, and our two honorary joint secretaries, Dr. Lilanti Subasinghe and Dr. Praveen Veeratunga, to the head table. May I now invite Vidya Jyoti, Professor Prasad Kadlanda, President of the Ceylon College of Physicians, to introduce the orator and present the orator's medal.
Good morning, ladies and gentlemen. It's my great pleasure to invite the orator of Professor K. Rajasuriya Oration. Professor Rajasuriya is a great clinician, an educator, researcher in yesteryears. So Dr. Asha Wettasinghe is giving her oration in the memory of late Professor K. Rajasuriya. Dr. Asha Wettasinghe is a senior lecturer I think she's a professor now, in physiotherapy at the Faculty of Medicine, University of Colombo, and the director of the Center for Physiotherapy and Rehabilitation. She established the Elderly Care Physiotherapy Clinic and leads the Geriatric Assessment Laboratory, pioneering geriatric physiotherapy services in Sri Lanka. She holds a BSc Honours in Physiotherapy and MSc in Exercise and Sports Sciences, and a PhD in Neurological Physiotherapy with her doctoral research focused on developing a falls risk assessment tool for people with diabetes mellitus. Dr. Wettasinghe has published extensively on falls and rehabilitation in older adults, collaborated internationally on aging research, and received commendations for research excellence. She is the editor-in-chief of the Sri Lanka Journal of Physiotherapy and Rehabilitation Sciences and actively contributes to national initiatives on geriatric care. Her academic, clinical, and research contributions are dedicated to advancing physiotherapy, education, evidence-based practice, and healthy aging in Sri Lanka. And on a more personal note, I had been knowing Asha for a long period as a physiotherapy undergraduate and subsequently as a postgraduate trainee. Let me invite Dr. Asha Wettasinghe to receive the certificate for the oration for Professor K. Rajasuriya Memorial Oration 2025.
Good morning, ladies and gentlemen, and thank you, Professor Prasad Katulandar, President of the Ceylon College of Physicians, for your kind introduction. I am deeply honored and thankful to be chosen by the CCP to deliver the Professor K. Rajasuriya Memorial Oration, and I'll start honoring him. Professor Kumaradasa Rajasuriya. Professor Kumaradasa Rajasuriya was born on 2nd December 1915. He received his early education at Ananda College at Nalanda Vidyalaya in Colombo. He entered the Colombo Medical College in 1934 and graduating in 1939. In 1952, he obtained membership of the Royal College of Physicians of London. He served as a professor of medicine at the Colombo Medical School. His contributions extend beyond academia. He was appointed as the Director of Health Services in Sri Lanka, where he shaped healthcare at the national level. In 1970, he was elected as the second president of the Ceylon College of Physicians. He also served as editor of the Ceylon Medical Journal. His distinguished career came to an untimely end with his sudden death in 1975. His legacy, however, continues to inspire generations of physicians in Sri Lanka. This presentation is based on the findings of my PhD study, which explored neurocognitive, sensorimotor, balance, and mobility impairments in older adults with diabetes. The focus is on these factors contribute to increased falls risk and the implications for screening and interventions in clinical practice. This is the outline of my talk. I will begin the introduction with a quotation by Professor Bernard Isaacs, a pioneer in geriatrics, which is a very powerful reflection on mobility, aging, and vulnerability. It takes a child 1 year to acquire independent movement and 10 years to acquire independent mobility. An old person can lose both in a day. The message is that mobility is precious, takes years to build, but is fragile in later life, highlighting why protecting function and preventing falls or disability in older adults is so important. Diabetes mellitus has emerged one of the greatest health challenges of our time. It is not just a disease. It has become a global pandemic. According to the World Health Organization in 2022, nearly 14% of adults aged 18 years and older were living with diabetes. This means that more than 1 in every 7 adults worldwide is affected by this condition, an alarming reminder of its scale as a global health crisis. In Sri Lanka, the prevalence of diabetes is estimated at 23%, one of the highest rates in Asia. This means that nearly 1 in 4 adults in our country is living with diabetes, a figure that underscores the urgency of addressing this epidemic at both clinical and public health level. One of the most serious concerns with diabetes is its complications, which are broadly classified into microvascular and macrovascular complications. Together, these complications reduce life expectancy, increase disability, and place a heavy burden on families and health systems. Falls represent one of the major healthcare issues for people with diabetes mellitus. A recent study by Freya and colleagues in 2024 reported 59% of people with diabetes experience falls. The risk is even greater among those on insulin therapy. Young and colleagues in 2016 found that 94% of insulin-treated individuals were at risk of falls, compared to only 27% among those not treated with insulin. These figures highlight the urgent need for falls prevention strategies in diabetes care, particularly for patients on insulin. The consequences of falls in people with diabetes are wide-ranging and can be grouped into physical, psychological, and socio and economic domains. Physically, falls may lead to fractures, soft tissue injuries, and head injuries. Psychologically, falls often create a persistent fear of falling. This fear leads to activity restriction, reduced participation in daily life, and physical deconditioning, which further increase the risk of future falls. From a social and economic perspective, the impact is equally significant. Many individuals lose their independence and may require institutionalization or long-term care home. Falls also increase healthcare costs and place an additional burden on families and caregivers. Altogether, these consequences highlight why falls prevention is such a critical component of diabetes management. Despite growing research on falls in diabetes, there remain important gaps. Previous studies have often relied on limited assessments, focusing only on one or two risk factors. Many studies also use high-tech tools that are not feasible in low-resource settings. This highlights the need for a simple, low-cost, and multi-domain falls risk model that can be applied widely, enabling early identification of those at risk and facilitating timely interventions. These are some of the abstracts we presented on diabetes-related falls and risk factors. And a systematic review on the impact of physical, neurological, and cognitive deficits on risk of falls in people with type 2 diabetes. The main objective of this study were twofold. First, we aim to assess the neurocognitive factors associated with falls in patients with type 2 diabetes and to develop a tool specifically designed to determine falls risk in those with diabetes. Second, we sought to rigorously test the reliability and validity of this newly developed falls risk assessment tool to accurately predict falls risk among patients with diabetes. The study was conducted in 3 distinct phases. In the first phase, we focused on assessing the various risk factors for falls in people with diabetes mellitus, including neurocognitive, physical, and functional domains. The second phase involved the development of a practical, multi-domain tool designed to identify diabetes patients who are at higher risk of falling. Finally, in the third phase, we rigorously tested the reliability and validity of this newly developed tool to ensure it accurately predicts falls risk and can be applied in clinical settings. We recruited participants with diabetes from endocrinology clinics at the National Hospital of Sri Lanka, as well as selected private clinics. For the non-diabetic comparison group, participants were recruited through community sources. All testing procedures were carried out in the neurophysiology laboratory at the Department of Physiology, Faculty of Medicine, University of Colombo. The study employed a combination of cross-sectional and longitudinal designs. The first stage of phase 1 was a cross-sectional comparative study, followed by a longitudinal study in the second stage of phase 1. The study sample comprised 3 groups. The study group A included 51 participants with type 2 diabetes and diabetic neuropathy, referred to as DPN group. Study group B consisted of 52 participants with type 2 diabetes but without neuropathy, called the DNO-PN group. Finally, the control group, group C, included 50 healthy adults without diabetes, serving as the healthy control OHC group. Participants for this study were recruited using a purposive consecutive sampling. Ethical approval for this study was obtained from both the Ethics Review Committee of the Faculty of Medicine, University of Colombo, and the Ethics Review Committee of the National Hospital of Colombo. Before the main study, we conducted a pre-test and a pilot test to ensure feasibility and refine our procedures. The inclusion criteria for participants with diabetes: participants were required to have type 2 diabetes for more than 5 years and age between 50 and 70 years. Additionally, participants needed to be able to ambulate household distances independently without the use of an assistive device. Participants were excluded from the study if they had evidence of significant neurological or musculoskeletal conditions influencing balance or gait. These criteria ensured that the participants included in the study could safely undergo assessments and that the results specifically reflected the impact of diabetes and neuropathy on falls risk. Data collection in this study was carried out using a combination of questionnaires, clinical assessments, and objective tests to comprehensively evaluate participants. First, an interviewer-administered questionnaire was used to gather demographic details, history of diabetes, duration of disease, medication use, and previous falls. Glycemic control was assessed using HbA1c testing. Neuropathy was evaluated using the diabetic neuropathy symptom and examination scores, vibration perception threshold, and nerve conduction studies of the lower limbs. Functional independence was assessed using the Barthel index. To track falls over time, participants maintained monthly fall calendars. Fear of falling was assessed with iconographical falls efficacy scale. Finally, the overall risk of falls was evaluated using the physiological profile assessment. In addition to demographic and disease-related data, the study assessed participants' vision and lower limb sensation, as there are key factors, as these are the key factors influencing the falls risk. For vision, we tested visual acuity using the logMAR chart under both low and high contrast conditions, edge contrast sensitivity using the Melbourne Edge test. Lower limb sensation was assessed across multiple domains. Proprioception was tested using a lower limb matching task. Tactile sensitivity was assessed using the Siemens-Wilson pressure aesthesiometer and vibration perception threshold with the bioaesthesiometer. Muscle strength and balance were also key component of our assessment, given their critical role in falls risk. Lower limb muscle strength was evaluated using the 5x sit-to stand test and knee extension strength measurements. Balance was assessed using several complementary measures. Postural sway, maximal balance range, and coordinated stability were all measured using a sway meter. Additionally, static balance was evaluated through the unipedal stance test as well as tandem and near tandem standing test. Gait and mobility were evaluated using the GAITA portable gait analysis system. Participants also completed the choice step-in reaction test using a step-in mat. The time up and go test, including the cognitive dual task version and backward walking, both with and without a dual task. Cognitive function was assessed using the trail making test A and B and the Montreal cognitive assessment. Visual reaction time was assessed using a mouse button click as the response. Postural sway was assessed using a sway meter. This graph shows how much the participant's body moves anterior-posteriorly and mediolaterally while trying to maintain the balance. Greater sway indicates reduced postural stability, a key risk factor for falls. Visual reaction times assessed by having participants press a mouse button in a response to a visual stimulus. Faster response indicate better visual motor processing, which is crucial for avoiding falls. Tactile sensitivity was assessed using the pressure aesthesiometer, vibration perception threshold with the bioaesthesiometer, and proprioception with the limb matching task. These tests quantify the sensory input needed for maintaining balance and coordinating movements. Gait was evaluated using a wearable sensor system capturing step length, speed, and variability. The choice step-in reaction time test assessed participants' ability to quickly and accurately respond to visual cues with coordinated stepping. Slower or inaccurate responses indicate impaired balance control and higher falls risk. For the development of the false risk model, 5 key domains were selected. Statistical analysis were performed using the starter software package. Negative binomial regression models were employed to assess potential predictors of falls. Number of prospective falls set as the dependent outcome variable. From each of the 5 explanatory domains, one significant variable with a p-value less than 0.05 was identified and included in the model. This approach ensured that the final model incorporated the most relevant predictors of false risks across multiple functional domains. In phase 3, we focused on testing the reliability and validity of the newly developed false risk assessment tool. This phase was specifically structured to test whether the newly developed false risk assessment tool was consistent, reproducible, and valid in predicting falls among individuals with diabetes. To assess test-retest reliability, the false risk assessment tool was administered twice to the same group of participants with a 2-week interval between measurements. Criterion validity was assessed using negative binomial regression analysis with the number of prospective falls taken as the gold standard outcome. This enabled us to evaluate how accurately the newly developed tool could predict actual falls during the follow-up period. For the test-retest reliability study, a subsample of 11 participants were selected from the main sample of 100 patients with type 2 diabetes mellitus. This group was reassessed after a 2-week interval to determine the stability and reproducibility of the tool. The purposive sampling method was employed for this phase. For data collection, several tools were employed, including balance measures, disease-specific measurements, and prospective falls assessment. The mean ages were comparable across the groups, approximately 60 to 62 years, with no significant difference. In terms of body mass index, the values range from 24.6 to 25.3 kilogram per square meters across the groups, with no significant differences. Overall, the groups were well matched for age and BMI. To summarize the key findings, the neuropathy group had a significantly longer duration of diabetes. Both diabetes group had higher HbA1c values compared to controls, but levels were worse in neuropathy groups. The number of prospective falls, risk of falls, and fear of falling, all three significantly higher in the diabetic neuropathy group. Comparison of cognitive functions among 3 groups. Significantly lower performances in the MOCA were found in the neuropathy group, and Trail B, simple reaction times, were different in the neuropathy group compared to healthy controls. These findings suggest that diabetic neuropathy is associated with measurable deficits in cognitive processing and reaction speed, which may contribute to increased falls risk. All the sensory measures, including lower limb proprioception, lower limb tactile sensitivity, and vibration perception threshold, were significantly impaired in the neuropathy group compared to healthy controls and diabetes without neuropathy group. Irrespective of having neuropathy or not, individuals with diabetes had the worst performances on sensation. Overall, these results indicate that diabetic neuropathy significantly impairs lower limb muscle strength, functional mobility, and gait, which likely contribute to increased risk of falls. Almost all the sensory and motor nerve conduction parameters had significantly worse performance in the neuropathy group compared to healthy controls. These findings suggest that subclinical neuropathic changes may be present even in the patients without clinically evident neuropathy, which could contribute to impaired lower limb function and increased falls risk. Postural sway was significantly greater in the neuropathy group across several conditions. These findings demonstrate that older adults with diabetic neuropathy have markedly impaired postural stability, particularly under conditions that challenge sensory input, which likely contribute to increased falls risk. Diabetes alone impairs maximal balance range, suggesting early sensory or motor changes. neuropathy causes significant additional deficits in coordinated stability, tandem stance, and single leg balance, indicating increased falls risk. Tests like the tandem stance and unipedal stance test are particularly useful for distinguishing neuropathic deficits. Overall, neuropathy was linked to slower, shorter steps, highlighting impaired mobility and potential falls risk. Visual function was also impaired in the neuropathy group. High contrast visual acuity was significantly worse in neuropathy group compared to healthy controls. Low contrast visual acuity showed similar patterns. These findings suggest that diabetic neuropathy may be associated with reduced visual acuity, particularly under low contrast conditions, which can further contribute to falls. This slide shows the journal publications that emerged from my PhD work titled Identified Sensorimotor Impairments, Postural Instability, and Risk of Falling in Diabetes with Diabetic Peripheral Neuropathy. This slide presents another journal publication titled Time Up and Go Performance and Associated Factors in Older Adults with Diabetes Mellitus. This paper identified that mobility, balance, and muscle strength are strongly associated with tug performance, highlighting its value as a simple bedside test to screen for falls risk in older adults with diabetes. Fall rates were significantly associated with non-modifiable risk factors, disease-specific risk factors, balance measures, and mobility and strength parameters. The variables selected from the 5 explanatory domains for inclusion in a falls risk assessment tool comprise diagnosed neuropathy, poor contrast vision, reduced knee extension strength, poor balance, and slow walking speed. This figure shows the proportion of participants who suffered multiple falls in the follow-up period with respect to the number of these risk factors present. Absolute risk for multiple falls ranges from 0% in those with 0 or 1 risk factor to 83% in those with all 5 risk factors. Absolute risk of multiple falls in relation to the number of risk factors in diabetes mellitus older adults. Risk factors comprise presence of diagnosed neuropathy, reduced vision contrast score, impaired knee extension strength, inability to maintain tandem balance for 30 seconds, and gait speed less than 1.4 meters per second. Selected model for fall prediction in diabetes older adults. For each 1 kilogram increase in quadriceps strength, fall rates decreased by 6%. And the inability to undertake the tandem balance for 30 seconds increased fall rates by a factor of 2.48. This slide highlights a key journal publication from our PhD, titled Falls in Older People with Diabetes, Identification of Simple Screening Measures and Explanatory Risk Factors. Evidence from previous meta-analysis has consistently shown that exercise, even as a single intervention, can prevent falls in older adults. Meta-regression findings highlight that programs offering a high challenge to balance and providing more than 3 hours of exercise per week are particularly effective in falls prevention. For balance training, exercise programs should include high level of challenge. This can be achieved by reducing the base of support, encouraging controlled movements of the center of gravity, and progressively minimizing the use of upper limb support. One well-recognized example is Tai Chi, which has been proven to be highly effective in preventing falls and improving balance ability, not only in healthy older adults, but also in those at higher risk of falling. Physical exercise is a key part of non-pharmacological management of diabetes. It provides multiple benefits, including improved insulin sensitivity, enhanced glucose uptake by muscles, and better glycemic control. When it comes to falls prevention, evidence shows that balance training and multi-component programs combining aerobic, strength, and sensory motor exercises are the most effective. Strength training alone has also demonstrated benefits, though to a lesser extent. In contrast, foot and ankle functional training has shown limited effectiveness, and it is not recommended as a primary fall prevention strategy. Meta-analysis suggests that older adults with diabetes can gain substantial benefits from exercise interventions that specifically target balance, lower limb strength, and gait. Interestingly, yoga has emerged as a promising alternative therapeutic approach, particularly for individuals with diabetes mellitus. However, more research with larger sample sizes is needed to confirm its role in falls prevention in this population. In conclusion, our study highlights that patients with diabetes experience multiple sensorimotor, balance, and mobility impairments. Those are often accompanied by a fear of falling and higher fall rates. Importantly, many of the identified risk factors are amenable to intervention. Falls in this population result from both disease-related and physiological risk factors. Our derived model identified two simple yet powerful predictors of falls: quadriceps strength and tandem balance ability. These can be assessed with low-tech bedside tests that have greater potential for widespread use in a routine clinical practice. From a management perspective, improving glycemic control is critical to reduce diabetes-related complications that contribute to falls. Early recognitions of the multifactorial nature of falls, along with timely referral to specialized falls clinics, is equally important. Finally, we recommend that balance and resistance training should be incorporated into the daily exercise routines of patients with diabetes as a key preventive strategy against falls. Now, to end my presentation, I need to show my gratitude, my appreciation, and give my heartfelt thanks to all those who helped me in my PhD journey. I would like to take the opportunity to sincerely acknowledge my PhD supervisors whose guidance and expertise were invaluable throughout this work. Professor Dilshani Disanayake from the Department of Physiology, Faculty of Medicine, University of Colombo. Professor Prasad Katulande, Department of Clinical Medicine, Faculty of Medicine, University of Colombo. Professor Lara Allett from the University of Applied Sciences in Geneva, Switzerland. And Professor Stephen Lord from the Neuroscience Research Australia in Sydney. Their mentorship, encouragement, and unwavering support were instrumental in shaping this research. And I remain deeply grateful for their guidance. I wish to express my heartfelt gratitude to my primary supervisor, Professor Dilshani Disanayake, for her exceptional guidance, mentorship, and constant encouragement throughout my PhD journey. Her friendly and approachable nature, along with her insightful feedback and unwavering support, made this journey both rewarding and enjoyable. I am deeply grateful for the invaluable role she has played in shaping my research and professional growth. I would like to acknowledge Professor Lord from Neuroscience Research Australia in Sydney for his invaluable mentorship and for providing me with the opportunity to undergo training at NEURA, University of New South Wales, Sydney. His guidance and expertise have been instrumental in strengthening both my research skills and the quality of this work. The completion of my PhD has not only advanced this body of research, but has also paved the way for a number of contributions to the field. These include strengthening multidisciplinary approaches to patient management and enhancing training programs to build capacity in this important area. This journey continues with a new milestone, the launch of the first ever Sri Lanka journal dedicated to physiotherapy. It marks a collective step forward in contributing to the growth of the scientific world. I would like to extend my heartfelt gratitude to all the staff of the Department of Allied Health Sciences, Faculty of Medicine, University of Colombo for their invaluable support and encouragement throughout this journey. I would like to sincerely thank Professor Vajra Disanayaka, the Dean of the Faculty of Medicine, for his support and encouragement throughout my doctoral journey. His guidance and the opportunities provided by the faculty have been invaluable in enabling me to complete this work successfully and to improve as an academic. I wish to express my deepest gratitude to my family, my mother, my father, my brothers, and my in-laws, my life partner, and my two wonderful children for their unwavering love, encouragement, and sacrifices. Their constant support has been my strength throughout this journey. Finally, I extend my heartfelt gratitude to the University of Colombo and to the Faculty of Medicine, which has nurtured me with knowledge, values, and inspiration throughout my journey. Like the flowers that bloom within its grounds, the university continues to flourish, and the sky remains the only limit for the Faculty of Medicine as it grows. It is with deep pride that I stay part of this legacy as my journey continues toward advance in the scientific world. Thank you.
Thank you all. May I kindly request the audience to rise and remain standing until the ceremonial procession leaves the hall.